Our speaker is Dr. Phillip Kasirye, who is the head of Mulago Hospital Sickle Cell Clinic in the Department of Pediatrics and Child Health at Mulago Hospital, Makerere University College of Health Sciences. He is going to speak on transfusion in sickle cell disease.
Thank you very much, Megan. The Sickle Cell Clinic is housed in just a few structures, somewhere in between Mulago, the upper section, and we have about slightly over 10,000 patients registered to date, and averagely on each month we get about 15 new patients confirmed with the sickle cell anemia. So it's not very good news to get that many patients each month, but maybe it's because of the alertness, the awareness of the burden that is going on. So I'm happy to be here and just present you some few aspects of transfusion in sickle cell. Largely, we're going to look at the new guidelines, the guidelines in the States, and how they fit in our setting. So we shall be discussing both. So that will be the flow of the discussion, a little bit of the background, structural and functional changes, the guides international and how they apply or they would apply locally. I will not go so much in the complications because they've been mentioned largely, but I'll just mention them in passing. As a bit of the background, sickle cell disease exists in several forms. It may be homozygous or heterozygous. Today we are going to discuss sickle cell anemia, that's the homozygous state. I think the laboratory persons are better at this, but if you looked at a blood smear, you'd see the normal discoid red blood cells with what appears like a hollow center. And on the far left, you would see in a patient with sickle cell anemia, cells that are crescent shaped. So briefly about the pathophysiology, I just want to say that what really takes place, what happens is a change, a mutation, a point mutation at position 6 of the beta globin gene, and this thymine replaces adenine. And so we have valine representing or being represented instead of glutamic acid or glutamine. So that change, point mutation, is what later on causes all these other abnormalities. Under conditions of low oxygen tension, that point mutation renders the red blood cell easy to form the crescent-like cells by a process called polymerization. So the hemoglobin molecules are drawn in a chain-like manner. And so they draw the cell into a crescent shape from the normal discoid shape. What this results into is a rigid red blood cell. And as a result, the major hallmark of pathophysiology is the blockage of these vessels. The smaller vessels, as the red blood cells that are sickle-shaped, clog. When they become rigid, they also actually become sticky. And so they cause that blockage or the vaso-occlusion, which presents in different forms as pain, or as cerebral vascular accidents, stroke, or organ dysfunctions. It's a more complex mechanism that may also include the white blood cells and other factors, but simply put, it results from the point mutation that occurs at that position 6. So, transfusions. Maybe just a little bit before I mention this is that additionally, the life or the half-life of these red blood cells, sickle red blood cells, becomes significantly shorter to a few days instead of the 120 days. And of course, that means that they will be easily destroyed, and therefore red blood cell transfusion becomes a mainstay mode of disease modification strategy. It does not cure, but it modifies the condition. So it applies both in children and adults to modify the disease. And here in Africa, it turns out to be one of the major modalities of managing patients with sickle cell anemia. And to that, we are glad to the blood transfusion, both at the center and the Mulago, because they consider us with high priority. And we pray that you continue doing that. So the goals of transfusion, in this case, the sickle cell actually, because of the deformed shape, has a less ability of carrying oxygen, and this is compounded by the vaso-occlusion. So the goal, therefore, in doing this red blood cell transfusion in sickle cell anemia would be to reduce the sickling percentage, the percentage of red blood cells that are sickled. Therefore, increase the oxygen carriage capacity in these patients. And we know that certain conditions like severe dehydration, which is commonly associated with infectious conditions, malaria is highly endemic in our environment, and other bacterial infections because of immunological dysfunctions in sickle cell anemia. So these predispose our patients to states of dehydration as well as hemolysis, and therefore the need for replacement with new or viable red blood cells. So briefly about the transfusion methods, maybe it has been mentioned before. There is a simple transfusion method, there's a manual exchange transfusion, and then there's erythrocytophoresis. Simple transfusion is just as it sounds, simple. After doing the necessary grouping, cross-matching, and then you do the transfusion. It's easy to perform because it usually involves one venous access. And once we take the precautions that have been mentioned or highlighted, it is simpler, but many times we flout them. So the only fear with this is that because our patients in this highly infectious, in this environment, tropical environment with so many infectious conditions, they are bound to have frequent episodes of hemolytic anemia, and therefore frequent transfusion. So there is fear or a danger of ion overload in these patients. With manual exchange transfusion, it requires, I have never done one, I must confess. So it requires a specialist who is well trained in conducting it, and you need a hematologist to be around. And what you do is that you may have more than one venous access, and actually you take out some bits of blood slowly, and then you do the infusion and transfusion with red blood cells. So it is time consuming, it requires a good environment free of infections, probably high dependence unit, and in our setting, for sure we don't have, we have limitation in space in the HDU area. In this case, the dangers of iron overload may occur, but they are less because you actually take out some red blood cells before transfusing with a new blood, which is devoid of these sickle cells. In the other one, which is erythrocytophoresis, it is very, very expensive. It requires highly specialized. And what they do is that they actually separate red blood cells, and re-infuse the patient with the other components devoid of red blood cells, and then they can replace with the new red blood cells. I have just read about it, but I have never seen it. But that would be the ideal in preventing iron overload. And given that our patients require frequent transfusions, how I wish we go to that level. And hopefully, we shall by 2040. So that's the vision we have for the country. By 2040, we should be a first world country. So going to the second part, I will actually now discuss the National Heart, Lung, and Blood Institute guidelines. These are the 2014 guidelines, and see how they can apply in our setting. I have already mentioned that much of the transfusions, what the indications for transfusion in our setting hinge on infections and the resulting hemolytic anemia. Largely malaria, but we also have bacterial infections. But we also have cases of splenic sequestration, where patients, due to so many factors, present with hyperhemolysis associated with huge spleens. And others that are rare would be like states of acute hemorrhagic states, maybe bleeding, due to any cause, but largely they are infections. So going to these guidelines, the aim of these guidelines, and I want us to really see whether we can take a leaf from them, is that they were set up to support care of patients with sickle cell disease in the US. And the background was that they got a panel of specialists. They were hematologists, they were specialists in blood transfusion, okay, and the different areas. That constituted an expert panel to come up with these guidelines. And of course, in the sickle cell area, they were focusing on health maintenance, acute complications, how to conduct transfusion, whether there's strong recommendation or moderate recommendation or weak recommendation drawn from this expertise panel on whether we should transfuse or we shouldn't transfuse. So the panel made, this is what I was saying, they made strong, moderate, or weak recommendation based on the expert opinion and the literature that exists. So it was evidence-based. And however, even where there was limited literature, they still made some recommendation basing on their experiences. Okay? I have not mentioned the people who are involved, but they are all leading experts in the field of hematology and transfusion. So, like I said, strong recommendation based on high confidence in evidence supporting the benefit. And it was actually expected that this would, where there is a strong recommendation, this would be like a rule, a guideline, a guiding principle, which should be applied to most patients with sickle cell disease in the States. Weak recommendations or moderate, what they really meant is that if newer evidence came out, maybe it would change the guides, okay? But they still suggested that in the absence of newer evidences, we would still consider it appropriate to either transfuse or not transfuse, as we shall see. So going to some of the indications that are highlighted in these guides, I will start with the strong ones. If you have severe acute chest syndrome, which is common in patients with sickle cell anemia, and the qualification is that there's low oxygen saturation of less than 90. So this would constitute severe respiratory distress in a patient with respiratory symptoms and underlying sickle cell anemia, plus or minus a febrile episode. So in these states, there is a recommendation that is strong enough that we should do exchange transfusion. And the other one would be acute splenic sequestration with severe anemia. This may be associated actually with hypotension. Similarly, there is a strong recommendation for transfusion in this case, in which case you can do a simple transfusion. Yes, this also applies in our setting. Acute chest syndrome with severe hypoxia would be one of the conditions to transfuse, but I know in our environment we would do a simple transfusion. And similarly, acute splenic sequestration may commonly be associated with hypovolemia or hypotension. So it would also warrant, and it's also apply in our setting. So the other one with moderate recommendation would be acute stroke. And in our environment, yes, that's another indication for transfusion in sickle cell anemia to prevent recurrence, and sometimes it also improves the outcome of that stroke episode. So one that has been fronted as weak, with a weak recommendation, is that one symptomatic acute chest syndrome with a slight drop in the hemoglobin concentration. Commonly, we haven't been transfusing all patients with acute chest syndrome. And I think in our environment, where we are trying to study hydroxyurea, I think it would also be an option. If you have a symptomatic acute chest syndrome without severe hypoxia. So this has been mentioned in passing in the earlier slide. And like has been stated in the second bullet, is that minor episodes, they also actually suggest that we may not necessarily transfuse. So transfusion would be left for the severe ones, especially the one that's associated with hypoxia. So going forward with the guidelines, the NHLBI guidelines, consensus recommendations. Here they didn't have much evidence to base on, but they borrowed from their experiences. And let's see how we would relate what they suggested to our environment. Hepatic sequestration, simple all exchange transfusion is recommended by consensus. I think in our environment, it will be very difficult to separate or delineate hepatic sequestration from heart failure. Because it would maybe present with tenderness, liver tenderness. So in the presence of a low HB of below 5 or below, this patient would also actually be transfused in our setting. Intrahepatic cholestasis, I have never come across this in our setting as warranting transfusion, but going by the recommendations in the States, it would require a simple exchange transfusion. And maybe we can look at these and see how we can develop our own guides of transfusion, just like it has come up in the earlier discussion. So if you have multi-system organ failure, they also recommend by consensus that it would require a simple or exchange transfusion. And I think we would agree, because if you had, for example, involvement of the CNS, central nervous system, in sickle cell anemia, that would be almost equated to stroke, an acute or chronic cerebral vascular accident. So in that case, we would also do a transfusion. In cases of aplastic crisis commonly associated with the parvovirus B19 infection, yes, it is not so common, but it is common in our environment. One of my colleagues did a study here and noted that it was actually existing in our environment. I don't remember quite well the prevalence rates, but patients would commonly present with anemia and with reduced reticulocyte counts. So in this case, we would do a simple transfusion as well. And just like I started with, any symptomatic anemia, we would also do a blood transfusion, and a simple transfusion at that. And of course, try to diagnose the underlying etiology and manage it. Commonly, we have malaria in our environment, and so we would recommend that being addressed as well. So going to the indications in surgery, they suggest that the patients be transfused prior to the surgeries to at least 10 grams per deciliter. Prior to any major surgeries, that would warrant general anesthesia. And it would also need a well-trained anesthetist to administer this anesthesia, because many times it actually would, I think it takes a longer time and aggressive monitoring. And so it came out as a strong recommendation that patients who are due for surgery should actually have their hemoglobin level elevated to at least 10 grams per deciliter. In those with a baseline hemoglobin of 8.5, it is recommended that, and who are due for minor operations, maybe like a circumcision, it would warrant use of hydroxyurea, which is not so much done here, but I think it would apply. Or a simple transfusion would also be actually safe in our environment for any kind of operation. So I want to refer you to one of the people who has done some studies, especially he is called Vichinsky and others. In 1995, they published in the New England Journal of Medicine, they published their findings from a comparative study regarding transfusion prior to surgical operations. And they looked at two groups of patients. Group one involved patients who were aggressively transfused. They underwent an aggressive transfusion program. In other words, the sickling percentage was reduced. The aim was to reduce the sickling percentage to below 30%. And they compared these to another group who were considered as conservative, who had a conservative approach in transfusion before the surgery. And here, they aimed at elevating the HB to 10 grams per deciliter with a range of 9 to 11. So when they compared these two, they wanted to see the effect, whether there was any advantage of whichever intervention in as far as the complications were concerned of the surgery and the post-operative complications related to sickle cell anemia. almost all of the parameters actually were similar. They looked at the non-transfusion complications relating to the surgery. They looked at the acute sickle cell related complications, the events, that's acute chest syndrome, and then the transfusion complications. What was surprising is that when it came to transfusion complications, those who had an aggressive program were twice likely to register transfusion-related complications, which meant that actually we needed to be a little bit conservative and just raise the HB to at least 10 grams per deciliter prior to the surgery, as opposed to aiming at the sickling percentage of 30% and less. So that is good news for us because less blood would be consumed and therefore more would be available. This has been mentioned in passing. So basically, I will not say much on this, but this was another study. This was another study actually that that compared no preoperative transfusion to preoperative transfusion. What it really showed, as you see in the table, in terms of all the parameters that were being monitored, it was safer to do some preoperative transfusion. But just like the previous slide showed, we need to be conservative and not overzealous, not aggressive. So as still with the guidelines, when they looked at children and adults with clinically overt stroke, they recommended that actually these patients need to have an exchange or simple transfusion. And also patients who have a high transcranial Doppler flow rate or velocity were similarly strongly recommended for transfusion, just like we do in our setting. Maybe just to mention, relating to the transcranial Doppler, we only have one facility. This is one hospital that has that that can measure the transcranial Doppler. That's Mengo Hospital. We can't do it at Mulago, National Referral Hospital. We hope we shall get to a point where we can do it. But this would be one investigation which would help us to identify those who are at high risk for stroke in sickle cell anemia, and therefore do transfusions as prophylactic, or rather start them on hydroxyurea to reduce their sickling percentage. Okay, basically, this slide just shows, we just wanted to show you what happens before and after a transfusion, in as far as the transcranial velocity is concerned. I mean, the velocity across the middle cerebral artery. So when you look at the reading, so the speeds were actually above 200 centimeters per second. So that was high flow velocity. That means this patient was at very high risk, okay? Very high risk for cerebrovascular accidents. After transfusion, well, there's a slight reduction. A slight reduction to the velocity is just around 200, but maybe with recurrent, it would go lower to below 200, and therefore, it will reduce the risk of cerebrovascular accidents in our patients. We have one of our colleagues is trying to study how to perform the transcranial Doppler in diagnosing our patients who are at risk at Mulago Hospital, and we hope at the end of it all we shall have that investigation available in Mulago. Okay, so basically, red blood cell transfusion in treatment of stroke patients, in patients with sickle cell anemia, the evidence was overwhelming in support for transfusion. That's a simple message. And I think this is what we will also take up here. There are some cases where I think we have sometimes overzealously or without knowledge transfused. And these people are actually advising that in such states we may not necessarily need to transfuse. So we could also co-opt this in our guides. Uncomplicated vaso-occlusive crisis or painful crisis. For cases of complicated or severe, persistent, unremitting painful crisis, there is suggestion for some exchange transfusion. But for uncomplicated ones, strongly advise us not to transfuse. In priapism, which is simple and has not lasted for 4 or more hours, it's also recommended that we should not transfuse. But if you have one that has persisted beyond 4 hours, you may actually need to do exchange transfusion in consultation with the urologist and the hematologist. In asymptomatic anemia, we may actually not transfuse, but just identify the other factors that may be related in its causation and also manage it conservatively. In acute kidney injury, it is suggested that we may actually not transfuse our patients if there is no other organ affected. It may be more detrimental, it may worsen the kidney function or impairment. So this brings us to what has partly actually largely been discussed by Professor Hume, the transfusion, the complication of RBC transfusion in our patients. And I'll just rush through them. We may have saturatory overload, where we don't critically follow the volumes, and this can happen in our environment. We may have hyperviscosity syndrome, especially if we've done a simple, this is more associated with a simple transfusion as opposed to the exchange transfusion and the other one. We may have alloimmunization. These blood products, I don't think we do just like my friend has mentioned. We don't look out for these antibodies. So we may have cases of alloimmunization, and therefore we have different forms of reaction. Hyperhemolytic syndrome, Professor has mentioned it, and iron overload. So just briefly, hyperviscosity reaction, basically there's resistance. The flow becomes slower, and as a result, it may actually predispose to further vaso-occlusion. That's what I may say here. And ultimately, there's reduced oxygen delivery to the different organs. So I see we need to learn exchange transfusion, because maybe it has happened and we haven't looked out for it. Okay? So the patient may present with features relating to reduced oxygen delivery to the different organs. The CNS, largely they may present with seizures or stroke, or actually altered level of consciousness and others. So the key thing is that as I read these guidelines, I also realized that maybe sometimes we do this, we predispose our patients to this. So we should avoid rapid red blood cell transfusion. And where there's indication for exchange transfusion, how I wish we were able to do it. So we should move towards that. And then we should take a conservative approach when transfusing, to at least to 10, but not above 10. And I see these as coming up prominently in our guidelines, which we, moving forward, which we should work on. I will not overdwell on this because they've been mentioned, but just to give you an example is this patient. Professor mentioned that this actually happened in a few days after transfusion. And if you see this patient, initially, there was the HB was maybe at about 6, just slightly above 6. After the transfusion, it went to 10. And then in a few days' time, the patient's HB came back to 2 grams per deciliter. So amongst the things that could cause that would be the delayed hemolytic transfusion reaction. So initially, you have a prop-up of the HB, but then the cells are actually destroyed because of allo immunization. And in a few days, about 7 to 8 days, you have the HB dropping even further below the baseline. So that brings into question our follow-up of these patients, how aggressive it is. At the sickle cell clinic, we do a transfusion. When we do a transfusion in our daycare facility and let them go, we advise them to come back. But the reality is that sometimes they have challenges in coming back. So I think going forward, these would be the patients to be admitted, and then we follow them up in a hospital environment where we can monitor. And then, this has been mentioned, I will not restate it. So the issues of concern with repeated transfusions in our setting, which is really taking place, the complete compatibility testing, just like my colleague at the hospital mentioned. We need, how I wish Mr. Ika was here, but you are his representative going forward. These are the things we should have. Why shouldn't we have complete compatibility testing at the National Referral Hospital? So this is not to blame, but these are things we should actually get doing. The risk of viral disease transmission, we are happy to the National Blood Bank. It tries to screen in as much as they can, especially for HIV, syphilis, hepatitis. We don't know whether they do parvovirus. So they don't do it. Maybe they don't do it. But we are in a setting where there are very many infections. Maybe some of those may be transferred to the patients. Iron overload, like I said, our mainstay mode of transfusion is a simple transfusion. So again, we need to be more empowered, trained to appreciate and identify iron overload and therefore manage it. And then the other is blood supply is actually limited in our setting. Partly because maybe the guidelines of transfusion are not well adhered to, and therefore we might be over-transfusing and causing, in part, this limited blood supply. So again, all this takes us to thinking about item number 1. These guidelines for the National Heart, Lung, and Blood Institute in the US give us an opportunity to come with our guidelines, the local guidelines that suit our setting. And so this is something I think that is timely, the workshop is very timely, and I think it is going to draw our attention to achieving this. We can achieve it, we just need to focus on achieving it. Just like the second bullet reads, most of what has been mentioned and recommended in the US can apply in our setting and should apply. We need to implement the methods to detect the alloantibodies, and I think that will be a one take-home message to our laboratories. And and chronic transfusion therapy remains a problem, yes, but I think also when we inculcate in our culture, when we bring it into our culture, that these patients who have been identified on a chronic transfusion program need to be monitored. We need to identify them and monitor, and we can do it. Just to conclude, I just want to say that one, I think we need to share, and one way of sharing is by publishing. So we're waiting for Mbarara. We shall not wait for Mbarara, but we hope to see what you have done and share in it, okay? And then the other thing is that good enough we have a committee in Mulago. I think we can do it. And once we do it, we can pass on this information through the training to the training institutions. I know Makerere is very receptive. Our department of PED would be very receptive of this, okay? So let us be strong and move forward and see that our guides are set up and are adhered to. Because what I purpose to do is that for any patient who is transfused on my ward and the clinic, and we can do it actually in a sickle cell clinic with Professor Hume, we can enforce it if we are supported by the lab. Okay? So thank you very much, ladies and gentlemen.